Well, hello and welcome everyone to the Lewis University Expert Panel focused on COVID-19. My name is Christopher Sent and I'm the Provost here at Lewis, and I'm delighted that we are doing this panel today with our three faculty experts. This event is part of a larger effort to bring faculty and their expertise to bear on society's most pressing questions and challenges. We take seriously our responsibility to inform both students and broader audiences about issues that impact the public good. Probably does not come as a surprise that COVID-19 is connected to many of the most pressing questions and challenges of the day. Its impacts on the public health, economy, the culture have been and will be profound, and our learning curve around the pandemic and its effects is steep and evolving. So we're very grateful to have help with that today. We have three faculty experts who will cover important topics such as the biology, public health, and psychological aspects of the COVID-19 pandemic, updating us on what is known, explaining the rationale behind various public health policies, and providing insight into the human response to the pandemic. So I'm going to quickly introduce our three faculty members just by name and title, and then they will go in the order that I present in the order that I introduce them. And we'll pause after each presentation for questions for a little while, and then move on to the next presentation, and then we'll have time for discussion afterwards. A reminder that there is a question and answer box and a chat box, I think, available to you in the audience, and so please use either one of those or whatever is available to you, and I will be checking it. And if you don't want to unmute and ask questions during that time. And that is a reminder that to remember to mute your microphones when you're not talking, or yeah, I think that's the way this works. We'll figure that out. And then, so without further ado, our three faculty experts are Dr. Jim Rago, Professor of Biology, Dr. Nanci Reiland, Associate Professor of Nursing, and Dr. Spencer Campbell, Assistant Professor of Psychology. So, Jim, I'll let you take it away.
Okay, thank you very much. One of the things that struck me about doing this project was, I was talking to a lot of students this semester about COVID-19 and all sorts of things like that. And I noticed that a lot of students that I have probably don't even remember the first SARS outbreak, which was probably about 2002. And what we're looking at now is basically the same virus in terms of its ability to cause disease, in terms of the signs and symptoms that it can cause, but it has managed to get a lot more widespread. And that's, a big part of what I'm going to talk about today. Why is it that this version of the SARS virus that, we saw an outbreak in China 18, 19 years ago, what is it that's made this one become so much more prevalent? So, this is a coronavirus. Coronaviruses are a pretty big family of viruses. There are a number of them that can cause diseases other than SARS. There's Middle East Respiratory Syndrome, MERS, if you've ever heard of that. A number of the common colds, or what we call common colds, 10 to 15% of them are probably caused by some member of the coronavirus family, but probably the most serious disease was caused by SARS about 18 years ago. And we're seeing essentially, like I said, the same profile of signs and symptoms in the patients, but it's just become so much more widespread. So a lot of times I would refer to it in class as kind of SARS 2.0. And like I said, so many of my students don't even remember the first one, so I'm getting old, I guess. But the virus has an incubation period of about 2 to 14 days. And what the incubation period is it's the time between when you're first exposed to the pathogen and you start showing signs and symptoms. So that can vary greatly by pathogen. Some pathogens have very short incubation periods. Like some can do it in less than a day. Think of stomach flu, norovirus. Others might take a month or more. This one is kind of on the shorter side for a virus. So anywhere between 2 and 14 days, with a median of about 4 to 5 days, they say, is the typical incubation period of this virus. And it takes about 11 and a half days for most patients to show signs and symptoms. After about 14 days, over 99% of all cases, if someone is positive, will start to show signs and symptoms. And I think the CDC still recommends that if you're going to, their base quarantine is about 14 days, but they leave, I'll let Nanci talk about this some more, but in a number of local and state other areas, they'll let you decide on your own quarantine rules. And that's what a number have done. Now, this is the thing that I think surprises a lot of people, the fact that you're contagious with this virus. You're most able to spread this virus to other people 1 or 2 days before you start showing signs and symptoms. And this is actually pretty typical for a viral infection. This is not something that's unusual or something that's COVID specific. So this is why people, at least the CDC, tell people to take the spread of this pathogen, the potential spread of the pathogen seriously, because again, you're at your most contagious. Virus numbers are typically at their highest right before you start showing, but by the time you start showing signs and symptoms, your immune system is pretty much already caught onto the problem and is taking care of it. But again, you're still able to spread these viruses the more of them you have in your body. And that's one of the things that's made COVID-19, SARS 2.0, so much more prevalent around the world. Now, another basic concept we talk about a lot in micro is the idea of the infectious dose. This is the threshold number of pathogens average you have to have in order for, a productive infection to be set up. And I don't know if you remember talking back in July, but the number has come down in the past 5 months since I did another talk with Nanci 5 months ago. It was, 1,000 to 2,000, they said a few months ago. Now they're saying that 100 in a lot of patients is enough to set up disease. And again, some pathogens have high infectious doses, some have low infectious doses. For a virus, this is a little on the lower side, so it doesn't take a whole lot of these. Now, if you're just exposed to 1 or 2 of these viruses, the chances of you getting sick would be virtually 0. So you have to be exposed to enough of these pathogens in order for you to actually get sick. And these viruses typically don't survive. They're really not alive to begin with, so I use the term survive loosely, but they've got a half-life outside of the human body of about 1 to 8 hours. And that's going to largely depend on what kind of surfaces these viruses might be on, how they might be traveling, if they might be suspended in aerosols, they might be suspended in droplets, they might be, again, on metal surfaces, wood surfaces, cardboard. All of that can affect how long the virus stays viable outside of a human host. And as far as approved treatments, again, 5 months ago, there was nothing that was formally FDA approved. Since then, in fact, this was probably only about a month or 2 ago, remdesivir was approved for use to treat COVID patients. And that's just, it's a drug that keeps the virus from employing an enzyme that it uses to copy RNA inside of host cells. So the bottom line is it's a drug that will halt viruses from replicating inside host cells. And they have found that it does improve patient outcomes. Convalescent plasma therapy and monoclonal antibodies, it's a similar sort of thing. When you're giving a patient convalescent plasma therapy, what you're doing is you're taking plasma from a person that's recovered from the infection and using that, just infusing it into a patient who might be at high risk or might be just at the beginning stages of the disease or might be suffering from a very bad case of the disease. What's going to happen is the antibodies in the recovered patient's plasma will attach to the viruses and allow the immune system to essentially do its job. When you give a patient monoclonal antibodies, you're typically giving them antibodies that were made typically in an artificial setting. So you made these in a lab, but the idea is the same. What you're doing is you're hoping to give these patients antibodies so that, again, that will help trigger their immune response and give them a more robust immune response, even if they're very sick. So in both of these instances, the point is to give the patient antibodies that were made someplace else that they can use for a brief period of time. And I will talk more about vaccines in just a little bit, but as you know, the Pfizer vaccine, which is what's called a messenger RNA vaccine, was just approved last Friday, and Moderna's version of the same type of vaccine, I think, was given preliminary approval today. So it will only be a matter of time before some of those are used in the again, I'm going to let Nanci talk about this, but it's not going to be long before we're going to be able to get probably one of these in the state of Illinois. And here's the picture of the virus that I think everyone is sick of seeing at this point. But one of the reasons that this virus has become so much more widespread, even though its signs and symptoms aren't necessarily as serious as what you might see with SARS 1.0, it's a mutation in this spike protein here. Sorry about that. That has enabled this virus to become so much more widespread around the world. This spike protein, this S protein here, is what enables the virus to attach to human cells. Specifically, it enables the virus to attach to what's called the human ACE2 receptor, angiotensin converting enzyme 2. It's a receptor found on lots of different kinds of cells, and obviously it's there to do something other than bind viruses that can come in and kill the cell. So this is something the cell uses for something else. The virus just exploits this and uses this receptor to bind to its host cell of choice and gain access to the cell. Now, one of the reasons this has become so much more prevalent is the fact that there's what's called a D614G variant, where what happened is we had a substitution of an amino acid in this receptor that enabled the virus to multiply to much higher numbers much more quickly. And it's just one single amino acid difference in this large protein receptor that has enabled this to happen. So what we see in patients that have this aspartic acid mutated to a glycine, that's basically what that means, we see that in the patients that have the disease, they don't necessarily get more serious signs and symptoms, but they do see a 4 to 10-fold, probably closer to the 10-fold increase in viral load per patient. And what that means is you see more viruses per patient. The number of viruses in that patient increases dramatically with this SARS 2.0, with COVID-19. So you didn't see anywhere near as many viruses produced in the patient with the original SARS. And that's one of the things that has enabled this virus to become a worldwide pandemic. So the increase in viral load they have found does increase the infectivity and the spread of the pet. More pathogens means greater likelihood for spread. Oftentimes it is that simple. Now, one of the questions they needed to answer early on too was this: does an increase in viral load necessarily correlate with more severe signs and symptoms? And for now, the answer to that question seems to be not necessarily, no. The signs and symptoms you see aren't necessarily as bad with SARS 2.0 as they were with SARS 1.0. So it's a very similar disease. It's just, like I said, that change in that viral spike protein is what enabled that virus to increase to higher numbers per patient and thus become more widespread. And as we talk about in class all the time, that's the ultimate goal for any pathogen when you think about it. Any life form, for that matter, is to become fruitful and multiply, to increase in high a number as possible and make yourself as widespread around the world as you possibly can. And like I said, this is the ACE2 receptor in a cell. Virus uses this. Is there an arrow? Like I said, I don't normally use WebEx. Is there, can people see this arrow I'm using, or is there like a finger pointer thing? Or just a pencil?
I cannot see the arrow.
Okay. But anyway, what you're looking at is this pink thing on the surface of this virus here binds to this green ACE2 receptor. And again, this green receptor on the surface of this cell is not there just for the purposes of binding viruses that can come in and kill it. It actually has a function outside of being something that viruses bind to. Okay, so like I said, the mutation in the spike protein does correlate with increased viral load per patient, increased numbers of viruses per patient, not necessarily with more severe signs and symptoms, though. Now, as far as the vaccines go, the Pfizer and the Moderna vaccines are what are called messenger RNA vaccines. And basically, a lot of people think this is, some rush technology. It's really not. This has been in the works for decades. People have been studying how to make these messenger RNA vaccines work since the 70s. But this is probably the first large-scale use of this technology, and necessity is the mother of invention. I do certainly think that a lot of the process for approval went quickly, but that doesn't necessarily mean it wasn't done properly. So what this technology allows us to do is make a messenger RNA, which is basically an instruction manual for how to build these viral spike proteins and give it to our own cells, it's a very simple, but it's a very brilliant approach. It's like a lot of great scientific discoveries, ridiculously simple. What we do is we just take a piece of RNA. Like I said, this RNA is read by this cell, or can be read by any cell, to make a protein. That's what the RNA is. It's a how to build a protein instruction manual. What we do is we give this instruction manual to one of our own cells and have our cells build this spike protein that might be found on the surface of the viruses as a way to, and immunologists use this term, prime the immune system, to show the immune system something they need to be on the lookout for. Now, we can give people antigens. We can give people, spike proteins or other antigens in other forms, more traditional types of vaccines. But one of the benefits of doing it this way is you get a much more robust immune response, much faster and much stronger if you show the antigens to the immune system cells this way. Basically, cells talk to each other by producing all sorts of chemicals. Showing antigens to the immune system cells this way allows for all sorts of chemical communication to happen between these cells that wouldn't otherwise happen if you delivered the vaccine in a different way. Or not as quickly, I should say. So that's basically how the messenger RNA vaccine works. You're using this viral, and again, when you give this messenger RNA to the cells, you're not giving this to them, you're not giving the entire viral genome to a person. All you're really giving them is one instruction manual, not the instruction manual for building all the other stuff the virus uses. So all you're doing is giving the instruction manual for the spike protein, which is kind of the money part of the virus. It's the part of the virus that enables this virus to do all the many things it does. So we're having our cells make this and show it to our immune system rather than the more traditional route of just adding the antigen and letting the immune system find it that way. So this is the vaccine, the Pfizer version of this messenger RNA vaccine that is currently in use in certain places in Illinois. Correct me if I'm wrong, Nancy, but I think Pfizer's version is the one that has been distributed to, that's what I thought, because again, Moderna's you can still ship the vaccines out before they receive final approval. But yeah, as far as I know, people are only getting Pfizer because that's the only one that's been fully FDA approved for use so far. Now, some of the drawbacks to doing antigen presentation this way is it doesn't tend to last as long. So with something like a messenger RNA vaccine, you don't get much time with this RNA molecule. This is not going to stay viable and readable within the cell for an extended period of time. What you're going to have to do is oftentimes get a booster or maybe two, but they've found that, they're saying that 2 shots does tend to give a pretty good amount of long-lasting immunity. But they're super easy to make, and they can be tailored to pretty much anything. And there are some other vaccines called viral vector vaccines, where what they do is they'll put some of the genes from something like COVID-19 into a different inactivated virus in order to deliver viral messenger RNA to cells. This has the advantage of being a little more stable. You don't have to put these at, in -70 freezers or anything like that, so they tend to be more viable for longer periods of time. AstraZeneca and Johnson & Johnson are working on versions of this, and as far as I know, for all 4 of these companies, their clinical trials have been fairly successful. I think AstraZeneca had a couple of hiccups here and there, but for the most part, the vaccines have been shown to be very effective, and there aren't a whole lot of side effects. And again, there are other more standard vaccines that are in the pipes too that might involve using just plain old inactivated viruses, just individual spike proteins. This is kind of similar to what they do when they give you a flu shot. They're giving you just purified spike proteins that are commonly found in the envelope of the influenza virus. Or you can give what are called live attenuated viruses, where you just take a living but severely weakened form of the virus and use that as a vaccinating agent. Okay, but this technology has quite a bit of promise, and it's really elegant. And should we ever come across some other infectious disease that's largely unknown to us in terms of its antigenic structure, designing a messenger RNA vaccine is pretty easy and can be done pretty quickly. So I think this technology could not have come into widespread use at a better time. The big stumbling block they had was when they deliver these RNA vaccines into our cells, what they do is they surround them with kind of a lipid sphere. And getting a lipid sphere that could carry these RNAs into our cells was something that took them a long while to figure out, but they have a working version that they're using right now, and that's essentially how they've done it. So, like I said, very simple but very elegant way to design a vaccine and to help people. And I'm glad that this finally came into widespread use at a time when we badly needed it. That's about all I had. Does anybody have any questions?
Thanks, Jim. And just a reminder, I think the best way to ask a question is to type the question into the Q&A panel.
Okay.
And while we see if anybody wants to ask you a question, I will ask a question.
Sure.
I have several, but one is just in terms of the messenger RNA, you mentioned that it's not clear yet, or one of its vulnerabilities is that it may not last long. And I'm just wondering how we would go about, or how researchers are determining how long it will last, and is that something that is being examined in the trials, or is that something that still needs to kind of play out as people are experiencing it?
Well, I think it's largely a limitation of the approach. I mean, an RNA molecule is only going to have a limited lifespan inside of a cell, whether it's something you made yourself or whether it's something that you had delivered from an outside source. But do you necessarily need the RNA to last for a really long period of time? And oftentimes the answer is no. I mean, if this RNA stays stable in this cell for long enough, that will induce this cell to make these antigens that can be presented. And once these antigens have been presented satisfactorily to the immune system takes it from there. You don't have to keep making this antigen in order to keep these immune system cells stimulated. So yeah, it might not last long. You might have to get a booster or two, but it's a small price to pay for an inventive way to present antigens to the immune system. Again, this doesn't have to be here forever. Once this immune system cell figures out what this antigen is and how to mount a response to it, it'll take it from there. And the RNA doesn't have to necessarily be stable for really long periods of time.
Yeah. Okay, so Jim, can you see the Q&A?
I can see a chat bar here.
Beneath that there should be maybe only I can see the Q&A. So I will assume that that's the case, and I'm not sure if I understand this question, so I'm just going to read it verbatim, and you might understand it.
I can see a chat bar here, but I don't know why I'm not seeing it.
There's also there's a Q&A section that maybe only I can see. So the question that came in is the immune response is immediate, and this is in the form of a question. The immune response is immediate, and the memory are antibodies longer term. Is that a good summary? Is that correct?
Well, anytime you mount an immune response against an antigen, basically what's going to happen is this immune system cell is specific for this antigen. Okay, this immune system cell was basically made to react with this antigen and only with this antigen. Now, when the immune system cells, specific immune system cells, B and T cells, B and T lymphocytes, when they mount a response against their antigen, 90 to 95% of them will be involved in that particular going after that antigen response. A small percentage of them, 5 to 10% or so, will become what are called memory cells. They'll be stored in immunological memory. So if this antigen were ever to rear its ugly head again, these memory cells will basically say, hey, I remember this antigen. That's my antigen. I'm going to go after it. So after you've been exposed to this antigen for the first time, you develop immunological memory. You develop a bank of cells that are designed to go after that antigen. And if it ever comes along again, they respond very quickly and very strongly. Strongly, is that a word?
Yes.
Very
I can do that. I'm going to ask one more
Does
question.
That kind of answer the question, though?
Yeah, I think so.
Okay.
I mean, we can hear from the question asker if that didn't respond to the question, but it sounds like it did. And then I'm going to ask you one more question, Jim, and then we'll hold other questions until later.
Okay.
What does remdesivir do now for patients that have come down with the virus? So I guess there's sort of a technical question about like how does it work?
Yeah, well, remdesivir, not to get into sickening detail, but coronaviruses are what are called RNA viruses. They have an RNA core. The core that they come with, the instructions they come with are obviously RNA. They also come with an enzyme that makes more RNA from an RNA template, from an RNA original. So they're using an enzyme called RNA-dependent RNA polymerase that will make more copies of their RNA core when they're replicating in a host cell for their own fiendish diabolical purposes. What remdesivir does is it keeps that enzyme from working. What it's going to do is keep that virus from being able to make more copies of its RNA core inside of its host cell. It's kind of like, in terms of how a patient responds to it, it's a lot like Tamiflu. It's one of those things where it's going to lessen the severity of the disease, but your immune system is still going to have to clean up the mess that was left behind. So it's something that will slow the progression of the virus. It'll reduce the number of viruses. It'll probably reduce signs and symptoms, but it's by no means a panacea, and it's by no means going to take care of 100% of the problem.
Great. Thank you so much. So I'm going to move on and ask Nanci to take over. Nanci, welcome. I know there are a couple other questions, but they may be appropriate. Jim, stick around, of course, and there may be more questions for you, but also some questions might be answered by the whole panel. So Nanci, welcome, and please begin.
Great. Thank you. So let's see. I think I have just a couple slides to keep me on track because there's just so much to talk about as we've been doing all semester. So I'm calling this, it's here, yay, but now what, right? There's a lot of information, a lot of sorting through information to keep us on track, keep us hopeful, and help us make our best decisions. I want to talk a little bit about what we're calling allocation. That's what we're really hearing a lot about now, right? These different phases of who is in line first to get these first batches of, right now, the Pfizer vaccine. The Moderna likely will be shortly, coming in batches. And it's, the word prioritization isn't really quite what it is. It's not meaning that people are, more connected, more special, that would be getting the vaccine first. It was a very deliberate group of panels that looked at what would be the most effective use of knowing it would be a limited supply in the beginning, and who would need to get the process, the logistics of getting vaccinated, who should be first in line. And of course, we've known that our people on the front line in healthcare have been greatly impacted. They've devoted and, given so much, committed so much to the effort to save and recover people from COVID, and they've put themselves greatly at risk. So those individuals, of course, are then one of the first in line. Up there with our 1A phase would also be a really important population that has been proportionately much more impacted than others, and that would be those living in assisted living, extended care facilities. That population is less than 1% of our national demographics, but have accounted for 40% of the fatalities from COVID. So really disproportionately impacted. So again, our residents of those facilities, along with those caregivers, would be within 1A. As we move through the other phases of phase 1 would be our first responders, our emergency medical people, police, other healthcare providers that maybe aren't identified as working with COVID patients, but just in the sense that COVID is rampant and anybody can be symptomatic or asymptomatic and come in for a dental visit or an eye doctor or whatever it might be. Those individuals would be in that first phase. As we kind of move down, it will be those with the independent living senior citizens, so likely 65 and older, and those with chronic conditions such as diabetes or other immunocompromised individuals that may see themselves impacted more should they become infected. And then we'll go and a lot of this is, the planning's been really important, but we're so used to being able to plan and set a deadline and set this is when it's going to happen. This has been really fluid, and as more information is available, as more knowledge about what is going to be available, what other products are needed in order for the vaccination to take place, it's had to be, kind of tweaked a little bit. So far, things seem to be going well. People are being vaccinated as we speak. In the Chicagoland area, we saw, I think it was New York yesterday, there was kind of promoting the first healthcare worker that was getting vaccinated there. So it is rolling out. Talk a little bit about the logistics and how this isn't really our normal, it's not like our flu shots. We're used to, we get a vial, now we often have already pre-filled syringes that we just unpack and we keep them in the refrigerator until we use them, and it's all good. The two vaccines that are coming out first are needing ultra cold storage for the Pfizer vaccine, meaning it has to be stored, I believe it's negative 79 or something like that. Things, it's not your regular freezer. It's ultra cold. It's like a dry ice type of cold. And those are special freezer units that are not available all over the place. So they've really had to see where those are available. Of course, people were trying to purchase them, and there's a certain supply and demand, and also protecting that cold chain. So you've seen on the news, there's a lot of looking at these special boxes that have the dry ice in them. So if they're coming from Kalamazoo, the distribution plant, how they're trucked by FedEx, by UPS to the planes that are specially equipped. There's been a lot of details that have had to come about. And as Jim said, we had the, Operation Warp Speed was the term they used in the U.S. It's really amazing to see that this is a global partnership, that every team has had to come in and share and work for a common goal of getting one or more of these vaccines available. And it's transportation and, all the way down the line. Some of the other logistics that are a little bit of a, consideration is that the two vaccines that are coming out first, both, as Jim said, need a booster within a certain amount of time. It doesn't mean it has to be done on the exact date, but in order to get that promoted boost of immunity, to get the maximized immunity, you would need to get the second dose, depending on what product you receive, either 21 or 28 days after the first. And it has to be the same vaccine that you got the first time, meaning if you got the Pfizer vaccine, you need to get your second dose of the Pfizer, not of Moderna or whatever other manufacturer is out there. So that is a little bit, tricky because we have to track people. We have to know what they need and be able to supply that second dose within that time frame for them to be protected. So there's a lot of technology, a lot of tracking, notifications that will go to people, you're due, this is where you get your second dose. So it's going to also, that's all well and good, we have the technology, but it really is going to be a lot of, responsibility on individuals to follow up and to pay attention to where they need to go and to, obtain their second dose. I want to talk a little bit about maybe some of the barriers or individuals that have concerns about getting the vaccine. They've done some polls, and I think the second poll that they did about individuals' propensity to get the vaccine, the numbers have gone up in a positive way. Initially, when we looked at it, there were maybe, 20% of folks said, yes, I'll be first in line, I'll get it. Others were, I'd rather wait a little bit. And then there was an equal amount that said, I'm not going to get it. Those numbers have changed, and I think it's a lot to do with the education that's out there, talking about clinical trials and that things may have been quicker than what we would have expected, but it doesn't mean that they weren't done with due diligence and with the critique that are needed. Our news media sometimes sensationalizes, that's how they get news headlines. So we would hear about a trial having to be paused because somebody had an adverse effect. And that is actually really good news. That means the trials were being done as they were supposed to. Anything that was an unexpected event caused them to slow down, to look at that, to review it, and knowing then that the trials continued, showed that that event was either minimal risk, was not related to the vaccine, was figured to be not something that would stop this vaccine from going forward. So that should give us some comfort in knowing that we didn't ignore those types of things. We addressed, the clinical trials addressed them. I don't have a lot of time to go into, vaccine hesitancy. There's a long historical background to that. Maybe Spencer will talk a little bit about that. But, we have to be sensitive and compassionate with those that may have hesitancy, and help educate and help provide to boost confidence, to talk about, to listen to scientific research and the findings, and kind of build up your health literacy around your decision to get vaccinated or not. The important thing, though, is we have to remember that this is going to take time. We have, 320-some million people in the United States who will need 2 doses, likely, unless we start using another vaccine down the line. That's only 1, but let's say we need, 2 doses. Right now, the population studied in the clinical trials really focused on those 16 and older. So that is the population that's being vaccinated now. Those under 16 are not being vaccinated. That will likely change by maybe summer or fall as clinical trials start to bring in more younger individuals and, assess whether it's, the dosing and spacing whether it's the same for a younger child or not. So in the meantime, so that's going to take a while. The masking, social distancing, getting tested is important. We kind of have ebb and flows of availability of testing. I think the states and the counties are doing a pretty good job of trying to get more accessibility, and to know that when your testing could be used as kind of a guidance of your risk, or as you maybe have individuals during the holidays that you may normally not see, but caution you not to use that as a pass or a green card. Testing just shows not even what your status is that day, because you can be in an early incubation stage, and especially a rapid test is not going to pick that up. So it's more information, but it really is not the full picture into what's going on. in your body that may put you and others at risk. So, rapid testing is really a bit better at picking up if you're symptomatic, in your early symptomatic days of having a positive. It has a higher false negative rate, meaning it could come up negative, but you actually are infected. The PCR tests, those are the ones that usually take a few more days, some 2 days, some 4 or 5 days, depending on how the labs are swamped. Those are a little bit more sensitive and are likely, if you've been exposed. The recommendation right now is if you've been exposed to somebody in close contact, to wait 5 days. So quarantine yourself during that time, but then test on around the 5th, 6th, 7th day. That's going to give you a better, more accurate result of whether that exposure resulted in you becoming infected. Okay, so next slide, if we can. Thank you. I just wanted to close up with talking about this. Really, we've probably learned more about public health than we've ever wanted, whether it's something that you've studied like I have or not. And this just really reminds us that public health is common good. It's not individualized care, although that is part of how we intervene, but really it's looking at the whole population, and it's looking at the greatest good for the greatest number. And sometimes that means some of that number may not agree or may be imposing some limitations, such as facilities being closed down for a while or not being able to do certain things. But the overall impact of those policies or restrictions is to protect the greatest number of individuals. That also brings up some the balance of public health policy is that it is protective of the common good, but we have to balance it with people's right to be autonomous. And sometimes that's tricky. Do we need, is it something we mandate? Is there enough proof that this intervention is going to save a lot of people and allow us maybe to get back to normal? Right now there's not a lot of, there's some discussion. There's a tendency to not want to mandate, especially when something's relatively new. But that kind of points to the more of us that can voluntarily prescribe and protect ourselves, we'll be protecting others too. With any kind of vaccination, and we see this with our children's vaccinations, and that we know that it's not just to protect that child from that disease, but it's also to protect other people that may not be able to be vaccinated, whether it's an allergy or a situation that they might have, or we have some of our vaccines that people can't get during a certain time. We have measles, mumps, rubella that kids can't get until they're over a year old. So that time prior to a year, they're very susceptible. And if we have other children and adults that can spread around any of those diseases, they're more likely to infect those children that don't have the protection. Finally, I wanted to talk a little bit about the global outreach and impact. I've kind of found myself, and I think maybe it's because I've been so focused on the care of our community at Lewis, right, that it's our little world and we have to watch out for our own and know what's going on in Romeoville, Illinois, or Will County. But we really have to remember, and Lewis has been wonderful about teaching us about globalization. And this really is a time for us to work together and not just look out, for number one. For us, it really has to be interventions that look at the most vulnerable. And if we are going to have a possibility of eradicating this virus, like we've done with smallpox and essentially polio, those were global interventions. It took a lot of work and a lot of determined individuals to reach those most difficult to reach populations. And provide education and vaccination and to work with them about trust issues, that this is something that globally was going to make an impact. And we know our world, thankfully, is very globalized. We travel, we share, but in order to do that safely, we have to make sure everybody is protected. So I did see there was a question, and I don't know, Chris, do you want me to ask about or talk about the immunity after somebody has a positive result?
Sure, go ahead. So first of all, thank you, Nancy. We did just get a note that when you are typing in a question, if you type in ask all panelists, then the panelists can see them. And I don't have to interpret them, which I actually enjoy doing, but probably more accurate if the panelists can see the questions. And then, and so there is a question remaining from before, and then please take questions now if you have questions related to Nancy's presentation. But yeah, please feel free to go ahead and talk about that question.
Okay, and that kind of it ties in both with testing and with even the vaccination. Just a couple points as I was reading that brought up that might be helpful. Right now for the vaccination, the only they say if you've been infected in the last 2 weeks, to probably not get the vaccine right away, to wait at least the 2 weeks. And our question is asking about immunity. Is there some immunity if you've been recently infected? And there likely is. The problem is this is a relatively new virus and immune response. So those indicators of or how much is protective or how long it will last are still being studied. Each month we're getting a little bit more information because we could track people. And recently the CDC has put out that the belief is that there's likely about a 3-month period where there is some immunity lasting in folks. Again, that may not be everybody. Everybody's immune response acts a little bit differently. So that is why right now, and even with retesting, and this has more to do with the type of testing because testing can pick up fragments of the virus. They're saying to wait 3 months before you get retested because you may continue to have a positive result even though you're not actually infected.
Right. Thank you. I have a question, Nancy. I just want to make sure I understood you correctly about the different groups of people who are who can get vaccinated, I guess. Are children and other populations like pregnant women, for example, are they not able to be vaccinated? And if I'm correct about that, when does that transition happen, or how does it get announced, or at the threshold where that's safe?
Right. Right now, children are, because they were not part of the clinical trial, are excluded from the vaccinations, but that is something that is already clinical trials are going on. So I would imagine that would likely be a few months before they get that data for that. Pregnant women, the latest I've heard is that they're not excluded, but to talk with their obstetrician or that about risk and benefit. Yeah, and I'm sure we'll get more guidance on that population as we continue to gather the information from our clinical trials.
So I've never paid such close attention to these approval processes before, so I feel like I should know this, but are these separate approvals or are they adjustments to the approval?
Mm-hmm. Right. So often they'll give they'll kind of give a thumbs up or a neutral or a negative. For kids, because there hasn't been data, they haven't given that approval. For pregnant women, it's kind of a neutral. There was not enough evidence to say it would cause harm. So that is where that's kind of sitting right now. Whereas the populations that were more fully represented in the trials were given a full thumbs up.
Okay, thank you. All right, I don't see any other questions in the Q&A, so I'd love to turn things over to Spencer.
Excellent. All right. As you can see, my name is Dr. Spencer Campbell. I'm out of the psychology department here. Specifically, I'm a cognitive psychologist. And my title of my thing is called Wear a Mask. Straight to the point. When I was asked to be on this panel, I was told to talk about the psychological aspect or impact on the whole pandemic situation. And I think when we think about it, there's a lot of psychology going on here. When we think about psychology, I think number one, we think of mental health. What's the ongoing mental health impact of a lockdown condition, for example? But here at Lewis, we're a university, so we're probably also thinking about learning. How is this impacting students' ability to pick up information? How's virtual learning doing compared to traditional? Then there's also social stuff, right? We've lost our ability to socialize face-to-face. We're a social species, so how does that impact us? But also some of us are thriving in this sort of social situation. We're actually expanding our network space off of digital platforms. There's a lot of psychology going on, but because I'm a cognitive psychologist, I focus on things like decision-making. And so what I want to talk about is the decision-making process between three groups of people that try to answer this question: why isn't this getting better? And it's because of this thing, right? It's because of the mask. It's a large part of it. A lot of people tend to be combative about the mask. We've seen this going on for months now. A right to choose to wear a mask mandates. What is a simple sort of piece of fabric has become a highly contentious political topic. And so what I want to do is I want to talk to you about three types of people that are surrounding this idea of the mask. And I'll explain why I'm talking about these people in a second. But here's the breakdown. I want to start off with the people who don't think COVID is real and talk a little bit about what's going on there. The other two groups are groups that believe COVID is a real thing, but they don't want to change their behavior, either because it would inconvenience them, or they don't feel like they need to change their behavior because they have a poor grasp on science or statistics. Now, I'm pretty confident that my fellow panelists and most of you watching here are not fit into one of these categories, but you probably know somebody who fits in one of these categories. And while you might understand that these people exist, you might not understand why they exist. So hopefully today I will be able to explain some of the psychology going on behind these groups so that we can get a better understanding of why the mask in particular, or just sort of COVID in general, is such a contentious issue. Let's start with the extreme. Let's start with the folks who do not believe it is real. This is the hardest group to talk about because if we were to look at a Venn diagram of people who don't believe COVID exists and a number of other conspiracy theories, it's a circle. It's not a Venn diagram anymore. These are likely people, and we see data that shows that these are people who tend to believe that 5G towers are out there to infect you with cancer, intentionally so. They believe that vaccines are microchipping or some other horrible concoction going into their body. Or they might believe in the incredibly dangerous and hateful garbage that is coming out of QAnon. This is dangerous people. And what I mean by that is they have a complete they live in a different reality than us. That's really, really hard to talk to somebody who lives in a different world than you, to try and bridge that gap and communicate with somebody like that. This tweet, it made the rounds on Twitter last month. I won't read through the whole thing, but it is heartbreaking. This is a nurse who tweeted her experience about COVID patients who are literally in the hospital dying of COVID, screaming at the nurses that COVID isn't real. Why are you wearing the masks? Give me the magic medicine. Joe Biden's going to kill us all. And they're literally dying of COVID. It's not just that they don't think it exists out there. They are experiencing it and still in denial. Mentally, this is a very different sort of phenomenon than what a day-to-day person is dealing with. Where is this all coming from? It's obviously coming from sort of an anti-science movement, but anti-science isn't a new movement. I talk to a lot of people who say that nowadays we're dealing with anti-science. And I get what they're saying, but I think we have to understand that people have been anti-science for a very long time. It's just louder now than it has been ever before. Nowadays, people who are flat earthers, who believe in some sort of concept like a deep state, anti-vaxxers, they have platforms now that allow them to spread these ideas like wildfire. But like I said, this isn't a new trend. The one example that I tend to talk to my students about is the MSG phenomenon and the sort of racism that was projected towards Chinese restaurants because it took one doctor writing an editorial where he complained about having a bad experience at a Chinese restaurant and blamed it on MSG. That then led to decades of racist behaviors and attitudes towards Chinese restaurants. And that's from an editorial in a newspaper. Now we have Twitter and Facebook and things like that, and it takes one celebrity to say something, and we get ripple effects of that belief. As was Nanci mentioned earlier, the media is also not super great at presenting science, and I think it's mostly for two reasons. One is they take a very scientific approach, and that makes it unapproachable. I think when people listen to science coming from scientists' mouth, it's hard to hear, and I think that's just a reality. It's overly complex. It's not boiled down for the every person to understand, or that is inaccurate. This is one of my favorite headlines. A friend of mine does research on creativity. He did a study on creativity and alcohol. And here's what the New York Daily News said about his study. It said that beer makes men smarter. That is not at all what Andy's study found, but it's a sexy headline, right? And you'd probably click on that and read it. And so this is a big problem. Just very recently, there was this monstrous editorial that was posted in the Wall Street Journal attacking Dr. Jill Biden, saying that she shouldn't be calling herself a doctor because she's not a medical doctor. In fact, they called her kiddo. This not only is a huge representation of just fragility in general, but is sort of part of this movement of anti-intellectualism or anti-science. Why is this happening? Well, a large part of it is just because of a lack of critical thinking skills or lack of practice with them. They might have learned these skills early on, but they don't use them regularly enough. And I think, honestly, this is an education issue. This is something that we need to teach our kids early on and reinforce consistently, specifically in science curriculum. I think if I think back to my science experience growing up, and I think back to some of my classes, it was a lot of definition learning and labeling models, and then that was sort of where it ended. And a lot of psychology courses are taught like that too. And I think we're not giving our kids the skills that they need to actively think about why they're learning what they're learning. And that's a big part of what leads to sort of this anti-science buildup. So let's talk about some of the other groups here. One of them, the other one is they don't want to be inconvenienced. They acknowledge the existence of the virus, but don't want to change their lifestyle to accommodate. And I think it's really important to know that this is something that spans the ages. This is not, I'm not trying to pinpoint a single age group and say it's their fault. We see this all over the place. I mean, look at this picture of a bar in Florida, right? These are students and young people who tend to lean more liberal or democratic. They're not immune to this sort of behavior, right? These are folks who can't imagine not having a Thanksgiving break where they spend it out at the bar with one another. Where does this sort of individualism come from? Well, it's because our culture is an individualistic culture, which means we look out for ourselves. We built our country on the concept of pull yourself up by your bootstraps, which is kind of ironic because the origin of that phrase means it's impossible, but we've sort of readopted it to mean you are overcoming things and lifting yourself up. We don't tend to think about the greater good. Again, something that Nanci was talking about earlier in terms of how we distribute something like a vaccine. Compare ourselves to other cultures that are much more collectivistic, where they think about the whole rather than the individual, and we're seeing startlingly different data on how the disease is impacting them. Let me show you an anecdotal piece that I think is interesting. My partner is from South Korea. Her father is a conductor in South Korea. This is an image from a concert that happened like a week ago. They are having full maskless concerts in Korea with a full maskless audience, and it's okay. It's safe. Could you imagine going to a choir concert right now? Choir, where the number of aerosols that are coming out are like outrageous compared to just a conversation. But they did mandates, and they went through with strict restrictions on how people were allowed to behave, because that is it's ingrained in the culture, is a sense of collectivism and thinking about the greater good, even if it means inconveniencing oneself. Here's just the data to show it again, right? In the Americas, we're seeing huge spikes right now. In cultures and in parts of the world that prioritize greater good or collectivism, we are seeing drops. This includes India, by the way. India is 1 billion people inside of it. The last group that I want to talk about before I talk about a little bit of psychology are the folks who have a poor grasp on stats or science. Again, these are not people who just don't believe in the virus. They just don't really understand it. And a big part of that is because they just never learned basic practices about statistics. In fact, this is something I teach in my stats and research methods courses. Human beings are pattern recognition machines, but we're also really bad at understanding things like probabilities on our own. That's why the concept of randomness just kind of breaks our brain. What this leads to are bad faith arguments. For example, the flu is just as bad. This is just as bad as any other flu. It's a bad faith argument. These tend to be the individuals who would do something like look up their symptoms on WebMD before a doctor visit and then tell the doctor what they have rather than asking the doctor to diagnose them. These are people who will Google something, find the first link that works with their beliefs, and then latch onto it. Here's an example. This was posted recently on Twitter. This is an individual who lost a loved one to COVID, and a person decided to respond while saying, well, only 1 in 3,000 die. Number one, that's a poor understanding of how the virus works from a mortality perspective, but what a monstrous thing to do to say that to somebody in their moment of loss. Why is this happening? How does this happen? I want to try and explain this with a few psychological theories and phenomena that might explain some of these groups. Certainly in 15 to 20 minutes, I can't explain everything, but let's try and get a little bit of an understanding. Let's start with this idea of conformity. Normally, we like to conform. In fact, it's something that we see all the time. Like I said earlier, we're a social species. We like being part of the in-group. We like being in groups. So we temporarily shift our behaviors. We change our attitudes to blend in. What we're actually seeing right now is a sort of anti-conformity because people are not they don't like being told what to do. This is not new. In fact, I spoke to my parents about this, and this was something that they talked about with seat belts in cars. Believe it or not, when seatbelts were passed as regulation, a lot of people thought, you can't tell me to wear a seatbelt. It seems ridiculous to hear it now, but that's a big part of who we are. We don't like being told what to do. Again, going back to that idea of an individualistic culture. But then I have to ask, are we individualistic? Because nowadays we're seeing something dangerous and sort of new. Or maybe, again, not new, but louder. Group polarization is the phenomenon where you will gradually, over time, change your beliefs and your actions and your behaviors to fall in line with a group that you have become a member of. A non-COVID example would be sports teams. If you become a new fan of a team and you learn about the superstitions of that team, you might think they're silly at first. Over time, the more you become a fan of that team, you buy into them. You believe those superstitions to be true. Now, that's a fun example. We are seeing that sort of group polarization in things like conspiracy groups and alt-right groups, like I was mentioning earlier, QAnon being one of the most dangerous and fast-spreading of those. We're finding people who attach their entire identity to a group that they are a part of in a way that's much more extreme than being a fan of a sports team. It's more akin to what we would see a textbook cult-like behavior. And that might start to explain some of these changes. Again, we've probably talked to or lost a friend or family member because of something like group polarization. Where are groups getting these beliefs, or where are individuals getting their beliefs? One of the things we talk about in cognitive psychology is the availability heuristic. It's a decision-making technique. It's one that actually tends to be useful to us. We like heuristics because it lets us do things quickly, but it can lead us astray. This one in particular means we make our decisions based off of whatever's most readily available to us. That oftentimes means whatever you just recently heard or the most emotional or salient piece of information. Meaning if you just saw it on Facebook, you're more likely to believe it than something that you saw a while ago that might be counter to that belief. This picture here is somebody who reads a headline about a plane crash saying they'll never fly again. Lewis is in aviation school. If everybody believed in that idea, well, we'd all be out of a job, right? But many people buy into this idea of the availability heuristic, and they drive themselves based off of it. So if somebody says something on Facebook, or your leader tells you something, you're going to believe it wholesale. You're not going to think about any other options. The last thing I want to talk about is this idea of cognitive dissonance, which is something that a lot of people are struggling with right now. Cognitive dissonance is an uncomfortable feeling. It's discomfort that we have when either we have two different beliefs that are at odds with one another in our head, or we have a belief and then we have our attitudes and they don't go with one another. Let's do a non-COVID example. Smoking causes cancer, but let's say you smoke. You're probably feeling some sense of cognitive dissonance, but you're able to overcome it for a couple of reasons. If you've smoked long enough, you just sort of have dampened that feeling, and it's an addiction. So the addiction helps override cognitive dissonance. If you wanted to stop cognitive dissonance entirely, you've got two options. You either have to stop the behavior, don't smoke anymore, or you have to change your belief, which is you have to somehow convince yourself that smoking doesn't cause cancer. So what does this have to do with COVID? Well, the idea that you might be wrong about something, that you might be wrong, or more dangerously, your leader might be wrong about a particular belief about something, the existence of COVID, for example, that makes you uncomfortable. So as a result, you will shift your behaviors and your attitudes to be, again, more in line with the group. This will lead to changes in beliefs that maybe you weren't so extreme before, but you go from like, it won't affect me, it's not so bad, to COVID is not real. That's the only way that I can feel good about not wearing a mask, is if I truly believe COVID isn't real. This is a bit hypocritical, the sense of wanting body autonomy, especially from the groups who are expressing it, because they want body autonomy in something like wearing a mask, but will refuse that autonomy of others in situations like the right to peaceful protest, a woman's right to choose, trans rights, any other thing like that. We can see that there's a bit of hypocrisy in the sort of, again, desire for autonomy. So I want to wrap up by saying two sort of takeaway messages. One, I think we genuinely need a new proactive way of changing the way that we talk about and teach science. And I say that again, as a scientist, as a psychologist, I think we tend to do an ineffective job of explaining things to people and making it approachable. That leads to anti-science, that leads to anti-intellectualism. The other major thing is that organizations and leadership need to be held responsible for the spread of misinformation and conspiracy theories. That is what is causing these things like group polarization and the availability heuristic to take hold. All I then ask is that you wear a mask. It's extremely important. It's not going to kill you, and you'll be able to breathe. And so that's what I want to end with. I want to thank you very much for your time. Thank you, everyone.
Thank you so much, Spencer. It's really interesting. I want to ask you a question, and then I see that there is a question in the Q&A for Jim, and I hope other people will type in questions while we're talking here. I guess I just want to ask you to extend that thinking a little bit that you were just doing at the very, very end there around how to approach the challenges with group decision-making or individualized decision-making that you presented. So I guess what would be, do you have any advice around positive or proactive and positive methods for persuasion around this challenge of this global health crisis that Nanci described, where we really need to be able to communicate and persuade people to behave, not 100% in the same way, but if persuasion is our best available method as opposed to autocratic modes of persuasion that might work, also, are there like approaches to that can be effective?
I think in the past, in other situations, I think there are. When we talk about persuasion, we sort of think about it in two flavors, although that's simplifying it. But one is we give the facts. It's a slow, methodical process of persuasion that here's the evidence, here's the facts. It's non-emotional. It's what we want to work. It's especially what scientists, we want that to be the method that works.
Yeah, and what you said about education helps with that mode that's slower and more comprehensive.
Exactly. And so we like that. We believe in that. But practicing that in real life with other people is ineffective because people don't want to, first of all, sit down and be lectured at with the data or anything like that. We talk about it more as sort of a peripheral route for persuasion, which is highly reactive, it's emotional and things like that. That's infinitely more effective than the route that I talked about. So it's very, I think it's, the concept of persuasion is nice. I like this idea, but I think we are running out of options in time for using persuasion as sort of as an individualistic method of convincing people about this. And I think it needs to be at a much bigger scale. And you mentioned the idea of autocratic versus, like something like autonomy. And there is a reason I put that South Korea example in here. It's because of mandates, that country is back to normal. And I don't think any level of persuasion is going to convince somebody to want to do that, because I think it's so baked into the American spirit of individualism that persuasion of a greater good is really, really hard.
Yeah, I get it. Thank you so much.
Mm-hmm.
Jim, we have a question. I don't know if you can read it, but
I can read it, yeah.
About the flu shot. Yeah.
Right. It's reported the annual flu shot's only 40% effective because the flu virus is constantly mutating. Speak to the mutation of COVID virus and how that will impact the effectiveness of the vaccine. Well, I will tell you this. Influenza, for a number of reasons, is really, really, really good at something called antigenic variation for a couple of reasons. Again, I'm not going to bore you with details, but other viruses look at influenza with kind of some jealousy because of their ability to do it and do it so quickly. And they have a couple of different spike proteins that are very prone to mutation. So you get with influenza a virus that's much more prone to mutation, and the virus is probably, the annual flu shot's only about 40% effective. I mean, that's give or take. I mean, it's 40, I think, is lower end, but it's still not all that high. You're right. Part of the reason for that is just because of the speed with which influenza can mutate. I mean, a year from now, you might have a completely different, you hear the H number, N number, like H1N1, H3N4. Those are the couple of different spike proteins you find. And every year, it seems like there's either new versions of the H or the N spikes, or viruses can acquire new combinations of H and N spikes that might already exist. So for a number of reasons, it's just, influenza is just better at it. At mutation. Now, COVID is no slouch. I mean, coronaviruses are prone to mutation too, but not as quickly. And as I was saying before, with the messenger RNA vaccines, we now have technology that allows us to respond to rapid changes in certain pathogens a lot more quickly. Now, I think a big part of the reason why COVID-19 is such a serious issue is because I think to a large extent, most of the world was kind of caught with their pants down. I mean, we were not expecting this big of a pandemic with a virus that, comparatively speaking, we didn't know that much about. I mean, we know a lot more about influenza, so that makes us able to respond more quickly. Does that answer your question, Bob?
He can't talk, but he can type it in. Yeah. Yay. Thank you, Bob.
And again, the vaccine will still be very effective. Could another version mutate and come along that would require us to make a new vaccine? Absolutely. But again, I think we know a lot more this time around. So if, God forbid, another version of COVID-19 spike protein or some other mutation happened with COVID that kind of made us have to develop another vaccine, we could do it a lot more quickly. And I think our facilities and hospitals and such will just be a lot more well prepared to deal with pandemics in general as a result of all this.
That's really interesting and helpful. Okay, great. I don't see any other questions. I would like to know if the panelists would like to say any final words before we go. Jim, you're unmuted, so why don't you go first?
Okay, I just want to say thanks to Nanci for all the hard work she's been putting in as far as hosting all these testing drives at Lewis. My wife came to one. She said it was very, very well run, and it was nice to have that handy for our students and for the community. So thanks for all the work you've been doing with that. And Spencer, I thought your talk was really interesting. I'm going to go back and watch the recording of it I think it will help me talk to people a little bit more effectively. Again, I tend to lean more toward the science nerd end of the spectrum. So stopping and thinking about how people are processing information is important, especially when people have their dander up and they tend to think in a certain way, and it's kind of hard to get that message across. So thank you for your part. I found that fascinating. Thanks.
Thanks, Jim. Nanci?
Yeah, it's wonderful to always be part of these collaborations because you learn so much, and it's just interesting to hear how everybody's experience and base of education and interest can come together and really inform all of us in different ways and open their eyes. And just want to wish everybody a very hopeful holiday season. I think we have a lot to be hopeful about, and I pray that everybody has a very healthy 2021.
Thank you. Spencer, any final thoughts?
Just thank you to my fellow panelists and everybody who put this on. I'm really glad that we had an opportunity to do this. I think this is really, really important work. So I'm happy to be a part of it. And just to consider thy neighbor, consider the group, consider the greater good, and it's good. I think we'll get through this. So, hey, I love it. I see Jim putting on his mask right now. So
right.
Thank you very much.
All right. Thank you, Spencer. Thank you, all three of you. It was absolutely excellent, stimulating conversation. We did record it, and we do know who the participants were, so we will find a way to make it available and publicize that. So it will be available to be watched again by our community. And if
the community has any other questions, then feel free to email me.
Yeah, please keep in touch with more questions as they come up, especially if you're, like we said, if you're watching this and you weren't here live, you know how to reach these people. I hope everyone has an excellent remainder of finals week and an absolutely restful and glorious holiday season. Take care and see you in the winter. Bye-bye.